Um, Thank you very much for the opportunity to present at the 21st ISDE World Conference of Esophageal Diseases in Brisbane, Australia. My talk's entitled Diagnosis and Perioperative Protocol to Identify Anastomotic Leakage. No commercial disclosures. I have, however, worked for the esophagogastric anastomosis audit and also the tentacle audit. This is the outline of my talk. I'm going to talk a bit about anastomotic leak healing or anastomotic healing. Talk a bit about the incident rates of anastomotic leaks in large series, which are particularly high. A bit about NG tubes, and then move on to routine contrast swallows, what signs to look out for, simple tests of either drain amylase or CRP, CT protocol, and endoscopic assessment of the anastomosis. It's been known for over 100 years that anastomotic healing, the mechanical strength of the anastomosis, arises from the esophageal submucosa, and healing occurs in 3 phases of inflammation, proliferation, and remodeling, and that maximum strength of wound healing occurs between 10 to 14 days. It's only in recent 10 years that we've had stable definitions of anastomotic leaks and conduit necrosis to make sure that when we report outcomes that they're standardized. So we now have a common language to compare data series. And these are some pictures of sadly anastomotic leaks that I've had in my experience: bile in the drain, big endoscopic defect, and a big collection on contrast swallow. And the rates of anastomotic leakage and conduit necrosis vary in the literature, and the rates vary between 11 and 19% for anastomotic leak, and 0.9 to 2.7% for conduit necrosis, which do seem high compared to other parts of the GI tract. And recently, alarming levels of anastomotic leakage of up to 30 to 40% have been seen in robotic oesophagectomy, and much lower rates with linear side-to-side staples. But for some reason, there's no information on the severity of anastomotic leakage in this series. I just wanted to make a quick comment about can we avoid NG tube placement after esophagectomy, and the answer from the Nordic group's multi-centre randomised non-inferiority trial is definitely not. Rates of anastomotic leakage were 22.1% if NG tube was avoided, and down to 15.2 with NG tube decompression for 5 days. So please make sure you leave an NG tube to decompress the conduit. I like the Shakespeare quote: defer no time, delays have dangerous ends, and the same can be true for anastomotic leakage. What are the signs and symptoms of anastomotic leaks? Well, they can be very barn door, or they can be look like searching for a needle in a haystack. Clearly, bile in the drain, a patient with severe sepsis or a neck wound infection has an obvious potential leakage, whereas patients who are not quite right, confusion, cardiac arrhythmias, temperature spikes, or slight tachycardia have to be proactively assessed, but may have other causes other than leakage. I wanted to discuss a bit about routine contrast studies to detect anastomotic leaks. These were in vogue in most centres around the world at various points, but the evidence suggests that they are poor. This is our study from some time ago, looking at routine swallows in intrathoracic anastomoses, and the overall sensitivity of the test was less than 50%. Leaks often occurred before the time frame of routine assessment, and the test risked aspiration pneumonia, and 70% of leaks were recognised clinically before the day of routine examination. And there's also a false negative rate of 2.5%. And similar findings were found in cervical anastomosis assessment. Poor sensitivity, accuracy was poor, and there was much higher rates of aspiration in the series of cervical anastomoses. And therefore these tests cannot be recommended for this reason. There are some better evidence that if you use them to confirm a leak when there's a high clinical suspicion, or you're using it to assess gastric emptying, it may have a role. But I'd implore you, if you do 3-stage or transhiatal oesophagectomy, the rates of recurrent laryngeal nerve injury are high, so that all patients with voice change or hoarseness must be assessed by a speech and language therapist routinely, as vocal cord injury can lead to aspiration and pneumonia. What about simple blood tests? Well, the evidence for CRP is pretty clear. This systematic review of 5,000 patients with an anastomotic leak rate of 13% showed that CRP had a very good accuracy at excluding anastomotic leaks, and if the level was less than 222 on postoperative day 2, development of an anastomotic leak was unlikely. And patients with a CRP of less than 127 on day 5 could be safely discharged. The value of CRP in detecting anastomotic leak at high levels is probably limited, however, because its elevated result can be due to other inflammatory complications such as pneumonia. Drain amylase assessment is a simple test. It's inexpensive. You need to be aware that amylase is an isoenzyme, so it does have salivary and pancreatic types. And it's used frequently in other operations, such as pancreas resection, etc. And it potentially may alert surgeons of an anastomotic leak prior to clinical signs or even a CRP raise. And there's been many studies on this. They're often small, they're often retrospective. They've shown different cutoffs for amylase level, and there's a varying sensitivity and specificity, which fits if your drain isn't immediately close to the anastomosis. It's difficult to see how a raised drain, how the drain amylase could actually be normal, but the patient could still have a leak. CT with oral contrast is clearly our main stay of assessing for anastomotic leakage, and I tried to look at the literature on this, and it's traditionally quite poor, but there is a reasonable study on the role of CT imaging done by this Dutch group. They showed that CT findings of leakage of oral contrast, a visible defect, air collections either around the anastomosis or the mediastinum, or fluid collections, pneumothorax, loculated effusions, or infiltration of fat at the anastomosis were associated with leakage, and they showed various images of these features in their paper. In addition, they came up with a score, so more than, well, 3 or more points in this scale showed an extremely high probability of anastomotic leakage, which was curious because one of the points was leakage of oral contrast, and you'd have thought that would diagnose a leak 100% of the time. Endoscopic assessment is safe, it's very accurate for leak detection. It has the benefit of assessing the gastric conduit for perfusion and can look for small leaks if the CT is normal. And it's absolutely ideal if the patient is intubated on intensive care, and then it can guide subsequent anastomotic treatment with either stent, sponge, or clips, etc. This study introduced a grading system depending on how much of the circumference was involved in the leak, the perfusion of the stomach looking rosy or necrotic, whether there's a cavity, and whether the anastomosis had issues as well. And these are various endoscopic pictures of various grades of anastomotic leakage seen at endoscopy. The Tentacle and OGA group have recently put this all together in a clinical consensus statement done by a Delphi consensus. In the paper, which is hopefully due to be published in Disease of the Esophagus shortly, we've come up with an algorithm which suggests that there's no evidence for routine assessment of the anastomosis. We need to monitor for clinical signs, monitor the CRP, consider drain amylase assessment, and if there is an anastomotic leak suspected, get a CT scan with oral contrast and an endoscopy if either the CT is inconclusive or the anastomotic leak is confirmed to aid in assessment of treatment. And I'd just like to finish off by recommending this paper, and this is a quote from John Alvaredi, a colorectal surgeon, and he says, according to conventional wisdom, an anastomotic leak can only have two causes, an error in surgical technique or patient factors. But he says this framing of an anastomotic leak in this way presents a moral hazard, and he's doing quite a lot of work on the microbiome and other things which are associated with anastomotic leakage, which are clearly neither related to the patient or the surgeon. I think this is a very interesting read, and I'd very much recommend everyone reads it. Thank you very much. I'm happy to stay and take questions. Thanks for inviting me to Brisbane. Thank you.